My name is Karen Warburton. I am a transplant nephrologist, and I also run a coaching program for graduate medical learners here at UVA, which I'm excited to talk with you about today. So I've been at UVA for about 4 years, and working with struggling learners has been a big part of my job for the last 10 years or so, and it's something I really enjoy. So I want to start by briefly reviewing some of the literature about struggling learners in graduate medical education, but really the main focus of today's talk is to give you a practical look at how we assess and coach residents here at UVA. So just to start by normalizing the issue, it's really common to struggle in residency. And most of the data on the prevalence of struggling GME learners comes from surveys of program directors across specialties. And I've listed these references here. And the prevalence really varies widely and obviously depends on how you define struggle, but it's typically between 5 to 15% in the literature, and that's really been my experience as well. And I'll just point out that this is in residence. There really aren't systematic data on fellows specifically. So what do learners struggle with? So the University of Colorado has been one of the pioneers in the field of remediation. And this is a figure from their seminal paper in academic medicine back in 2014. This is their experience with 150 or so trainees over a 6-year period. And here they look at learner deficit by training level, and they're really the only program to have published data like this, so I find it very interesting. So here the black bar represents medical students, the gray bar are residents, and then the white bar is a smaller group of post-residency learners. So just to highlight a couple of interesting findings here. So you'll see that mental well-being was more commonly an issue among medical students. And then medical knowledge and clinical reasoning are really common at all levels. And I think what's really interesting if you look in the middle is to look at professionalism, which is increasingly seen as trainees advance. This is an interesting finding, and there are, I think, many potential explanations for this. We could probably have a talk on this topic alone. You know, I think our expectations change as learners advance. Certainly our modes of assessing trainees evolves. And my anecdotal experience is that professionalism does become a more common issue the more that a learner gains confidence and experience. So how frequent or successful is remediation according to the literature? So there's definitely been an uptick in publications about remediation in the last 5 to 10 years. And yet the answer to this question is still not totally clear. Most studies with any outcomes data involve students and are focused really more on improvement of test performance. There are some subspecialty societies who have formed task forces focused on remediation. Emergency medicine and surgery are 2 notable examples of this. And then there have been a handful of successful centralized remediation programs that are written about, again, the University of Colorado being the first, and then University of Pennsylvania, and then here at UVA. But really, even despite this, there are no best practice guidelines for remediation. Dr. Karen Hauer from UCSF has proposed this as a model for the process of remediating a struggling learner. And this model, which was published back in 2009, has really provided the framework that most of us use for remediation, certainly the programs at Colorado, Penn, and UVA. And this begins with a comprehensive assessment of the learner, followed by a diagnosis of deficiency, development of individualized learning plan, and then the remediation itself. And of course, all of this requires an effective relationship with a mentor or a coach. And then following remediation, there is reassessment and certification of competence. So really building on this model by Hauer and building on the experience of programs at the University of Colorado and the program that we started at Penn in 2014, we started COACH here at UVA in 2016. So COACH stands for the Committee on Achieving Competence Through Help. And the credit for this name goes entirely to Dr. Brad Kesser, who's a member of COACH. And I should just say that Dr. Kesser was integral in us getting this program off the ground, as was Dr. Kirk, Susan Kirk. And what we've tried to do with COACH is to design a program that allows there to be some separation between the assessment of a learner and the coaching or remediation of a learner. So assessment is what is done by the attending of record and by the program leadership and by the programmatic clinical competency committees. In contrast, our coaching program is not involved in the assessment of the learner and does not contribute to the learner's evaluation or milestone scoring in any way. This, we hope, allows the program directors to just be but to be program directors, and gives learners a safe space to deal with whatever issues they're dealing with. And so these are the basic tenets of Coach. And that is that we know that some learners will want or need coaching during their training. And we, at this institution, we being program directors and Coach, and of course the GME office, want all learners to succeed. And we're all committed to putting into place the resources that are necessary to help learners who do struggle. So just a word on terminology. So the term remediation means something different at different places. Here at UVA, there's a specific GME policy on remediation, which is publicly available, and you can read about it if you're not familiar with. Here, remediation is a pre-disciplinary process that's really designed to help the learner. But nevertheless, I think the term remediation can carry some stigma with it, and at some institutions, it does connote disciplinary action. Similarly, the term coaching also means different things at different institutions. But I use it here to refer to the process of individualized mentorship and guidance from an individual who's both committed to the learner's success and also not directly involved in the learner's reassessment. In other words, not the program director. And one of my goals in developing Coach has been to create a program or a process that really encourages early identification and referral of trainees before remediation is necessary. So how does referral work for Coach? So there are basically two routes for a learner to get to us. So a learner may self-refer to Coach at any time. In this case, nothing is shared with the program leadership and nothing is kept in the learner's file. Often people self-refer because they are dealing with burnout or mental well-being issues, or maybe there are clinical performance concerns that have not yet reached the level that puts them on the radar with their program leaders. I've actually had two self-referrals this week, one for COVID-related stress and the other for kind of earlier performance concerns. And then, more commonly, the learners are referred to us by their program director. This may or may not be part of a formal remediation plan. And in this case, we do communicate our recommendations with the program leadership, and we're always very transparent with the learner about what information is being shared and with whom. So this flow chart describes the approach that we typically use for a learner with clinical performance concerns. So this chart and the next several slides are really most applicable to the program director-led referrals. And we'll come back to self-referrals a little bit more at the end. So following referral, Coach performs an assessment, which I'll talk about shortly. A primary clinical performance deficit is identified in one of the following categories. So medical knowledge, clinical reasoning, organization and efficiency, professionalism or interpersonal skills, and communication. And I should add that we have a sixth category, and that is procedural skill. I need to update this slide. And we chose these categories at Penn when we developed our program back in 2014. And I would say that this categorization is really based on just observation of what our students, residents, and fellows have struggled with over the last 10 to 20 years. And for those of you who are familiar with the ACGME competencies, you'll notice that not all of these things are competencies. In general, I have not found the competencies to be particularly helpful in designing coaching and remediation plans. The best example being patient care, which is just an incredibly broad competency and encompasses so many different skills. So following assessment and identification of the clinical performance deficit, Coach develops an individualized written coaching plan, which is carried out either by Coach or at the departmental level, depending on what the issue is. The learner is ultimately reassessed by a group that is independent of the coaching process, which is typically the program's clinical competency committee. If an underlying mental health condition is suspected during the initial assessment, Coach offers the learner the option to refer for additional assessment or treatment with a mental health professional. We do work closely with psychologists, psychiatrists, and other therapists, both at UVA and in the community. And these referrals, when they're made, are completely confidential and are never shared with the program leadership. For coaching and remediation to be effective, we have to make sure that we understand what the problem is in the first place, and this can take some digging. So we spend a fair bit of time on the assessment process in Coach. And again, I want to be clear that I use the term assessment here to mean the Coach assessment, And that's done just to inform the coaching process and is not part of the official assessment of the learner, which informs the learner's milestones. The coach assessment process occurs in 2 phases. The reconnaissance phase involves a review of the learner's written file, a review of performance in the prior program, if this is available. And I typically like to talk directly to people who have worked with the learner. Ideally, it is helpful to directly observe the learner myself, although I honestly rarely do this in the clinical setting given issues with stigma. But we do often perform direct observation in a simulated setting, and we'll talk a little bit more about this when we talk about the actual coaching process. So following the reconnaissance phase, we typically do a 60 to 90-minute interview with the learner. I do most of these, and during the interview, I really just try to get to know the learner and understand their perception of the problem at hand. And I really want to stress how important it is in this process to understand the why, and in other words, kind of how we got here. So learners who struggle with clinical performance often have a lot going on under the surface. And often if you don't ask directly, you may miss some of these things. So part of the coach assessment is to consider the things that I list here. And this is a list of conditions that I've compiled over the years of working with folks who struggle. So the first thing I'll highlight is stress. And there are obviously many types of stress that affect learners in their 20s and 30s who are going through graduate medical training. Probably the most common in my experience is family-related stress. But there are also issues with stress related to careers, finances, health, and the spillover of problems in any of these areas into work is very common and can contribute to performance issues. Anxiety and depression are also quite common among struggling learners. Personality disorders or features of personality disorders are less common, but may underlie certain types of struggles, particularly those related to professionalism. Impairment is always something to consider when you see that a learner is struggling. And I just want to highlight here that there are different types of impairment, not just substance use, but also fatigue and medical illness. Cognitive dysfunction and learning disorders may underlie certain performance deficits, and it's important to consider these. I'm actually working with several learners now with ADHD, and for some this is a new diagnosis. For many it's a diagnosis that was made or considered when the learner was young. And for many, I've noticed, in the last several years that there is some stigma to carrying this diagnosis. And although for others, it's actually such a relief to sort of have a label that helps explain some of the things that they've noticed in themselves. But I'll just say it does come up frequently in our coach evaluations. And then there are just, sort of a list of other potential contributors such as burnout. Sometimes people make the wrong career or the wrong program choice. And oftentimes coach can provide support related to career or program redirection. We've done this a couple of times in recent months and it's gone quite well. And then finally at the bottom, I have begun to make this list of personal attributes or characteristics that I've seen contribute to either the likelihood that a learner will struggle and or the influence that they have on a learner's ability to respond effectively to coaching. And these are things like maturity, reliability, honesty, ability to reflect, insight, willingness to change. I think that insight and ability to reflect are 2 of the most important prognostic factors for successful coaching and remediation. In my experience, struggling learners often have trouble identifying feedback and or they can't actualize the feedback that they get. And they may have blind spots. And so part of the work that we do in coach is to help these people better incorporate the feedback that they're getting and better learn from the direction and feedback they get on the wards. So while we want to steer clear of ever diagnosing our learners, I put this term in quotes for a reason. I do want to stress that it's critical to pinpoint the actual performance deficit, and this can be challenging. I think correct categorization of the primary deficit requires direct observation, and there are obviously many barriers to doing this, most notably time, stigma, maybe lack of comfort or expertise, to name a few. And ideally, the assessment should be done by someone with some level of expertise in remediation. So probably the most common learner chief complaint that we see in coach are I would say definitely number one is needs to read more or struggles with medical knowledge. Probably the second most common thing is are complaints that a learner is disorganized or inefficient. So in my experience, needs to read more is usually a signal that something is wrong, but it's often not knowledge. And so the challenge in these cases is really differentiating a true knowledge deficit from usually from a clinical reasoning deficit, and we'll come back to this. But I think many of us are so attuned to assessing knowledge in our learners that we tend to, when we sense that something's not quite right, we tend to latch on to knowledge because it's something that we know how to assess and how to fix. It's just not always exactly what's going on. So how about the resident who appears disorganized or inefficient? So in my experience, there can be many things going on here. You know, for some, there truly is a problem with organization or time management, and often there are clues to this when we interview the learner. I often ask if the learner pays his bills on time or what her desk looks like at home. There may be specific issues related to the system in which the learner is operating in residency. Maybe they're unfamiliar with EPIC. Maybe their prior program didn't prepare them for the volume and acuity that they see here at UVA. And you know, coaching for organization and efficiency issues really focuses on teaching the learner systems that can be used to complete their daily work. And often peer coaching can be useful in this case if it's not too stigmatizing for the learner. Probably more common than a true problem with organization is the resident who appears disorganized who actually has a clinical reasoning deficit. And the apparent disorganization here is really the learner's inability to gather data effectively and efficiently in a compressed time frame, or an inability to triage information, and therefore the learner is perpetually running behind, whether it's for attending rounds or in clinic or when doing a consult. Clinical reasoning coaching looks quite different from coaching for organization and really involves quite a bit of diagnostic work to identify the lesion in the clinical reasoning pathway, and then ultimately work on targeted exercises that, that sort of get directly at that lesion. And we'll come back to this shortly. And then finally, disorganization or inefficiency can be the single presenting sign of an underlying issue with mental well-being. So I think it's really important to dig a little bit and to try to differentiate between these things, just because the coaching for these three different issues is completely different. So just to go back to our differential diagnosis here, and I want to focus the next few slides specifically on the assessment of medical knowledge, clinical reasoning, and professionalism. So Coach's assessment of knowledge is fairly straightforward, and as I said before, most of us are fairly comfortable with this, so I start with it because it's probably the easiest one to assess. I kind of think of all learners as having a tank of knowledge. And for some, that tank is just more full than others. I think that, you know, as with everything, direct observation, content-related questions and discussions with evaluators are very helpful in teasing out knowledge versus, say, a problem with reasoning or application of knowledge. We always review the learner's performance on standardized tests. We go back as far as we need to. And then in the interview, we spend a lot of time really trying to understand how they've prepared for the tests that they've taken or for the work that they've done so far. So what are their study habits? Specifically, how much are they studying and how effective is the studying? Often there is a lack of committed time or there are distractions. And so we try to address those explicitly and learn to mitigate them. We ask about history of learning disorders, mental well-being issues, as we talked about before. I like to talk to the learner about whether their test performance in the past reflects the knowledge that they felt that they had in the tank prior to taking the test. And if not, what are the barriers to allowing that knowledge to show through in a test score? We certainly review trajectory. Have they always struggled, or was there an abrupt drop-off in scores or performance? An abrupt drop-off or change in trajectory can signal an underlying issue with mental well-being. Is the knowledge deficit global, or are there specific areas of concern on which we can focus? When there is an in-training exam score available, these can be extremely helpful because they often give a score breakdown based on the area, and often learners have very inconsistent scores based on exposure, so we can correctly or appropriately target a reading plan. And then I mentioned this before, but I always talk about the role of performance anxiety or poor self-confidence. I've worked with many learners, I'm working with two now actually, in which this is the case, who have plenty of knowledge in their tanks, but they tend to freeze on test day or on rounds. And so it's very hard for them to demonstrate this knowledge to the evaluator. And in these cases, cognitive behavioral therapy and mindfulness exercises can be very, very helpful. And just acknowledging that this is what's going on can sometimes be incredibly empowering for the learner. So as I mentioned before, one of the most important distinctions is for us in coach is differentiating a true knowledge deficit, again, which is the tank just not being full of knowledge, from a clinical reasoning deficit, or the learner's inability to effectively apply their knowledge to the care of a patient or a test question. Clinical reasoning issues, in my experience, are much more common among graduate medical learners than true knowledge issues, and they often get mislabeled as knowledge issues. And these are, I've listed sort of some common observations of learners who struggle with clinical reasoning. I'm sure you can think of learners who exemplify some of these. So probably the most common would be difficulty with patient presentations, just because that's such a common way that we evaluate learners. People who can't see the forest for the trees, people who don't get it, people who struggle with complex cases. There's a typical phenotype of the learner that does well with simple cases, but then can't seem to apply the skills when the patient is more complex. People who are unable to summarize a patient in one line, the one-liner, that's called problem representation. That's a critical clinical reasoning skill. A learner who orders too many tests or is uncomfortable with uncertainty. A learner who can't create or prioritize a differential diagnosis. Someone who can't structure an admission or clinic visit efficiently, who can't agenda set. Again, that can look like organization, but it may be a clinical reasoning issue. And then people, this is management reasoning rather than diagnostic reasoning, but people who can't triage a task list or recognize urgency or discern sick versus not sick. We do a lot of coaching for learners where this is the primary problem. And then we're all familiar with the common cognitive biases that lead to errors in clinical reasoning, anchoring or premature closure being a very common one, availability bias, visceral bias, to name others. Typically, we break the diagnostic clinical reasoning pathway into these components: generation of hypotheses, data gathering, problem representation, which is that one-line representation of the patient I mentioned, pattern recognition and illness script retrieval, and then script selection and diagnosis. So when a clinical reasoning deficit is suspected, the coach assessment typically involves some simulated work in a coach's office, working through cases to identify the lesion or lesions in this pathway. So switching gears to talk about the assessment of professionalism. This is a topic that makes many people cringe. It's actually one of my favorite areas to coach. And I think of professionalism as being a very heterogeneous category that encompasses both behaviors and character traits. I tend to group the issues into these categories. So there are people who struggle with interpersonal skills. They're the kind of the rule breakers, lying, cheating, stealing. Then there's the trainee who doesn't take ownership, is unreliable, or who doesn't recognize his or her limits. And then kind of this separate, more egregious category of sexual misconduct or abusive behavior. And I can't stress enough for professionalism issues the importance of understanding the why. If you concentrate just on the behavior without exploring the origins of the behavior, it may be very difficult to actually help the learner. So I'll give you a few examples to make this point. These are, I'm going to list 3 common examples of behaviors that come to coach under the professionalism label. This is where I really like to give the talk in person so I can get some audience participation, but I'll just imagine what you might say. So the first is the learner who doesn't respond appropriately to urgent situations. So occasionally this is truly a professionalism issue, that of laziness or unreliability. But I would say this is the minority of cases, and usually it's something else, although this does often get labeled as a professionalism problem. So there are other additional explanations for somebody who doesn't respond appropriately to urgent situations. Maybe the learner has a knowledge or a clinical reasoning deficit and doesn't recognize that the situation is urgent or doesn't know how to respond. Maybe the learner has performance anxiety. I worked somewhat recently with a learner who had a tank that was plenty full of knowledge, really smart person, but would freeze, literally freeze in urgent situations, specifically in codes. And it turned out that this was a performance anxiety issue. And this is somebody who responded beautifully to cognitive behavioral therapy and is doing great. Probably a more rare example would be somebody who's on the spectrum and just is unable to recognize the cues that would lead the person to recognize the situation was urgent. So there's a differential diagnosis. And again, just assuming it's professionalism, you know, is assuming a lot about intent that we don't know for sure without examining the underpinnings. Okay, so what about the learner who's consistently late or doesn't show up? Certainly this can be a professionalism issue, and this not infrequently is a professionalism issue, and it may be other things as well. This can be a sign of burnout, a sign of impairment. I had a student at my last institution who presented for his sub-internship in his field of choice and was 2 hours late every day the first week of the rotation. And when I was the director of the sub-I at the time, and I confronted him and he said, "Oh, sorry, I just overslept." And it just kept happening. And finally, about a week into the rotation, he admitted that he had narcolepsy, that he had gone off his meds because he was worried about the potential stigma of being on medication. And that sort of shame had kept him from coming forward. And we were able to get him in with his sleep doctor, get him back on his medication, and he repeated the sub-I and earned a grade of honors. So medical impairment is something that needs to be considered in these cases, as is substance use, fatigue, other forms of impairment. And then, you know, a person who struggles with organization and time management may have a hard time getting places on time. And then there are obviously other potential explanations related to mental well-being. So again, worth digging a little bit when you see somebody who's consistently late. And finally, the resident who is rude to the front desk staff in clinic or who loses her temper easily with nurses. Certainly we've all worked with or potentially even been this resident. You know, so often I work with people like this who claim that they're just advocating for their patients. And so I think this concept of patient advocacy, particularly for trainees who possess features of what we call the compulsive triad, who are perfectionists. This is a very common set of traits among physicians that may lead to, at times, unprofessional behavior in the name of patient advocacy. It's possible that a resident who behaves this way learned to behave this way in their own families. Maybe this is how they were spoken to, or how they learned to get things done early in life. And so a lot of what we do in coach when we assess someone like this is to go back and do what we call family of origin exercises to get at what people's home lives were like early on and where they learned to behave the way that they behave. And then, you know, as someone who behaves this way may be burned out, they may be depressed. This is not an uncommon way for depression or burnout to present. So again, I think the point is clear. It's important to dig beneath the behavior if you really want to help someone. Okay, so moving on from assessment to coaching itself. So this is back to Hauer's model, just to remind us all that remediation, which is what's circled here, is really just a cycle of three things: deliberate practice with real-time feedback and time for reflection. And deliberate practice looks different depending on the skill. It could be performing a specific procedure. It could be developing an appropriate differential diagnosis. It could be handling a MET call. It could be not yelling at a nurse when you're triggered. It's practicing the skill, whatever that skill is. So when coach develops an individualized coaching or learning plan, we typically start with 3 to 5 goals, and we like the SMART goal framework. So this is goals that are specific, measurable, hopefully attainable, relevant, and make sense within the time frame of the coaching or remediation period. We typically lay out in the plan where the coaching will take place. It often begins in someone's office, either a domain expert, so a clinical reasoning coach, a knowledge coach, a professionalism coach, and then moves eventually to the clinical learning environment once some basic diagnostic work is completed and the skills are introduced. The simulation center can be a tremendously effective environment in which to coach learners. not just for procedural skills, but also for things like communication and professionalism. And this is something that we are hoping to further develop in GME here at UVA. In terms of who are the coaches, it really depends on what the issue is and which department the learner comes from. The coaches may be domain experts. As I mentioned, we have clinical reasoning coaches. I'll get a little bit more into our clinical reasoning coaching program shortly. The coaches may be peers. Sometimes I use peer coaching for people who are trying to develop effective organizational systems. And then once the learner's coaching plan moves back into the clinical learning environment, we begin to involve the evaluating attending of record to help structure direct observation and the giving of real-time feedback. So the timeline is typically laid out by the program, both the timeline for coaching and the timeline for reassessment. And if I haven't made this point already, I just want to state that the reassessment is always done by the program, never by the coaches. The coaching and assessment processes are completely separate, and I feel very strongly about this, and that's sort of built into the structure of coach. So I'll briefly now, just in the interest of time, I'm going to briefly outline the principles of coaching for each of the three areas that we just discussed, so medical knowledge, clinical reasoning, and professionalism. I'll start with medical knowledge, not because it's the most common, but because it's typically the easiest of the clinical performance deficits to remediate, and generally has a favorable prognosis as long as the learner is engaged and any potential underlying contributors are correctly identified and appropriately managed. But I'll say that a knowledge remediation plan, an effective one, typically needs to go past this command of read more, which is what learners are often told. You just need to read more. The assessment typically gives us a lot of clues as to what the problem is, whether it's not enough studying or it's ineffective studying. We assess for distractions, we try to mitigate them, we assess study habits, we examine the test-taking experience, as we've already discussed. And we typically establish an objective so that the learner has something concrete to work toward. A common one would be sort of working toward the next in-training exam or the boards. And one of the most important principles is that learning should typically be symptom-based rather than disease-based, which to better simulate how the learner will encounter patients or test questions. So I'm a medicine doctor, so I would say a learner should not go read about gout, but instead should go read about acute monoarticular arthritis, because the patient's not going to come in and say, I have gout. They're going to come in and say, I have a red swollen knee. So we structure the plan according to clinical presentation. We like to identify a coach, whether it's a member of the coach committee or whether it is a member of the learner's own department, again, depending on the content area. And then we have the learner develop a list of clinical questions, again, using in a symptom-based format. Then the learner researches answers to these questions and presents the list, the reading plan, and ultimately the topic presentations to the coach. We help them make the schedule. We have the learner own it in the name of self-directed learning. The topics ideally should be as closely linked to the learner's rotations as possible. And then I like to assign questions, ideally contextually, and the learner should review their incorrect answers with the coach. So it's this contextual assignment of questions. So if the learner was reading about acute monoarticular arthritis, in medicine, I would probably assign them 10 of our board review questions for rheumatology. And then the idea is that you don't, that you continue to focus on the answers that you got incorrect and do more reading around those or more teaching rather than continuing to review the questions that you're getting correct. And these strategies, when put together, tend to promote retention, and they tend to make learning more enjoyable than just telling the learner to go read. So I mentioned that clinical reasoning is a much more commonly encountered deficit than medical knowledge, at least among graduate medical learners. So what we've developed, it's so common that we've decided to develop a clinical reasoning coaching program as an offshoot of Coach. And this is led by myself and Dr. Andrew Parsons from the Department of Medicine. So Andrew leads a group of 13, it's actually now 15 faculty members that represent 9 different departments. I need to update this slide. And our mission is really twofold. So one is to train members of the committee in a standardized approach to the diagnosis and coaching of clinical reasoning deficits. And two, to develop what we hope will be durable materials that a variety of academic departments at UVA can use for coaching. And we've had some success so far, and this has been one of my favorite committees to be a part of. So this is a really busy slide that illustrates our approach to problems with diagnostic clinical reasoning. As I mentioned earlier, the coach works with the learner to identify the lesion or lesions in this pathway, from hypothesis generation to data gathering to problem representation to refinement of hypotheses to development of a working diagnosis. And then we have identified exercises targeted at each step of this pathway that can initially be undertaken in the coach's office and then later in the clinical learning environment by the supervising attending. And there's so much more to clinical reasoning coaching that is not depicted here. We're working on some tools to assess and ultimately coach management reasoning. This here is really diagnostic reasoning, but management reasoning is another area in which we get a lot of referrals. And specifically, our committee is focused on working to develop an assessment tool for learners' ability to recognize and respond appropriately in urgent situations. So lots more to come, hopefully, from this committee soon. All right, so my favorite topic, remediating professionalism. So I want to briefly introduce a very simple framework for understanding professionalism issues that was given to me by one of my mentors at Penn. Her name is Dr. Carol Zoe. Her brother is Calvin Chow. They actually pronounce their names differently. Calvin co-wrote the Blue remediation book with Adina Collette that many of you who have read about remediation may be familiar with. Carol is an internist at Penn, and she does most of our GME professionalism work in the Department of Medicine, and she has taught me so much about how to think about this topic. So I want to give her credit for this framework. So she categorizes or separates people into can't, won't, or oops. So can't refers to a person who behaves unprofessionally because he or she hasn't learned the norms or doesn't know the rules, or is having trouble following the rules despite having good intentions. So maybe someone who grew up or trained in a different culture, who isn't familiar with the mores at the current institution or culture, someone who has learned this way of behaving from their own family, or maybe somebody who is impaired by depression or anxiety or a processing problem that impedes their ability to behave professionally. And won't refers to somebody who really knows the rules but chooses not to follow them. And this could be somebody who is operating out of love or greed or mania or has a personality disorder. And then oops is just a mistake. We all make them. So it's important to make this distinction because we deal with these differently. And this again speaks to the importance of getting at the motivation and the underpinnings of the behavior. So for those who make mistakes, for the oops group, we tend to provide support. Oftentimes, a management of an oops situation, provided that it's not singularly too egregious, is we sit down and have a cup of coffee with them. At Vanderbilt, they call this the cup of coffee level intervention. And we often it's appropriate in these settings to also examine the learning environment because that so often contributes to these oops scenarios. The way we deal with can't is we coach. The can'ts are the most amenable to coaching because we can teach professional norms and we can teach boundaries and we can teach by narrative reflection so that people better understand how their behavior is being perceived. The won'ts typically need discipline. They need consequences. They need a letter. They need to be put on probation. They need someone that they respect to call them into the office and give them what I call the career limiting talk. And that is, if this behavior continues, this will be career limiting for you. That can, for the right person, that talk can be very, very effective. And I think for the most part, while not everybody neatly fits into one of these categories, and I think we readily recognize that, I think oftentimes the differentiation between the can't and the won't can be extremely helpful in knowing how to proceed. Won'ts don't tend to respond very well to coaching unless there is something that you can reverse. All right, so in the last few minutes, I want to share some of our data from Coach. So in the last, so this is over approximately a 4-year period since I came to UVA. We've had about 70 referrals, which amounts to just about 8% of all of GME trainees over a 4-year period. If you'll remember that 5 to 15% figure that I showed you at the beginning. So this is about what I would expect. We've had referrals from 14 different departments, so a wide representation across graduate medical education. 1/3 are self-referrals, and this number makes me so happy, and I hope that this number continues to grow. I think that, and I would say we've also seen an increasing number of self-referrals in the last year. And to me, this makes me feel like we are potentially moving the needle on the stigma associated with coaching and or remediation. And people are more comfortable admitting that they're struggling. And we love self-referrals, so we encourage them and welcome them and hope that this number continues to grow. The most common deficits as categorized by coach, professionalism is probably the #1, followed by organization and clinical reasoning, which are just about tied. Knowledge is quite a bit less common, although not zero. And then communication we've only had a handful of straight up communication issues. And I separate some people ask me, well, what's the difference between professionalism and communication? Professionalism really incorporates some of the interpersonal interaction stuff that we see around, let's say, someone who is yelling at people or behaving aggressively towards someone else. Whereas communication is more people who struggle to communicate effectively with their patients, people who struggle with nonverbal cues, people who struggle with getting their ideas across, but aren't necessarily having a lot of conflict. So that's sort of how we differentiate these. Coaching looks a little bit different. I just want to highlight one slide about underlying mental health conditions. If you'll remember the slide I showed you earlier about the long list of things that underlie clinical performance deficits, we've found at UVA that nearly 40% of learners referred to coach have an underlying mental health concern. And as you'll see in the pie chart, this is most commonly anxiety, followed by depression, with a handful of folks with ADHD and some other conditions. Among struggling learners who have underlying mental health concerns, professionalism is the most common type of clinical performance deficit. So that's what's shown in the bar graph to the lower right, followed by clinical reasoning, organization efficiency, medical knowledge, and communication. So we think this is interesting. I have looked at this with Dr. Amit Shahane, who is a psychologist here in behavioral health, who is part of COACH, and who ends up seeing a lot of the referrals from COACH when our assessment does suggest that there may be something else going on. If he doesn't see the learners himself, he will help with referral to the appropriate mental health professional. And we're very struck by this number, and I think it warrants additional study and consideration, and is certainly not something that's been reported exactly this way in the literature. So important. And again, a big part of what we do in COACH is to help get learners resourced in a way that's confidential and is not shared with the program. So I have not included an outcome slide here just because I'm sensitive to confidentiality issues, given that the numbers here are still fairly small. I mean, you can look at outcomes among struggling learners in lots of different ways. You can report the stage of remediation action. So in other words, how many learners have successfully completed coaching versus are still being coached. Then you can look at whether the learner is in good standing in their respective programs or not. You can break this down by subgroups. You can look at milestone scores, pre and post intervention. We have not done that. I have not made it a practice to go look at learners' milestone scores, although I would like to do this eventually. I'll just say anecdotally and in a very general way, our outcomes are largely descriptive, but are generally good. The majority of the learners who've gone through the COACH program have benefited in that their performance has improved and or they've reported improvements in subjective well-being, which is great. And to me says that we're helping. We have not done, at my last institution, we did some focus groups to look at learners' perceptions of coaching. We have not done that here, although that's something that I'd be very interested in doing. Again, my anecdotal experience is that the majority of learners have been very grateful to have the opportunity to go through the process, even those who were skeptical about it at the beginning. All right, so just a couple, or one more slide. So I just wanted to go back to self-referrals because we spent a lot of time talking about program director-led referrals. So as I mentioned, about a third of our referrals are self-referrals. We welcome these, we love them. Self-referrals take courage, I think, and insight. And we really love working with learners with courage and insight. I may meet with a self-referral once, or probably more commonly, I will develop a longitudinal relationship with the person. I may end up handing them off to, or I often end up handing them off to one of my colleagues at Coach, depending on what the issue is and personality match, et cetera. And, you know, oftentimes we meet with these people for the duration of their training, either regularly or on an as-needed basis. And these relationships are so rewarding for us and hopefully for the trainees. We've had learners self-refer to talk about career changes, burnout, stress management, mental well-being issues, performance anxiety, family stress, adverse events, difficulties in the learning climate. Again, we're a diverse group of faculty on Coach, and part of my job is to pair the learner with the right faculty. And so our goal is to create a safe space for learners to discuss these issues and to provide learners with specific resources in a confidential environment. So that's all I've got. I just want to acknowledge the following people who have made this program possible. Susan Kirk and Diane Farino have been tremendously supportive as we have set this program up, and continue to both of them continue to provide ongoing mentorship for me and help with institutional policy. And they also are a great source of referrals for us. Brad Kessler is a member of Coach, and as I mentioned, came up with the name for Coach and has been integral in getting the program set up. Carol Zoe, my mentor at Penn, who has helped me so much with professionalism coaching. Amit Shahane, another member of Coach, who is really my right-hand man and has done a lot of the work with mental well-being. And finally, John Shorling, my mentor here at UVA, who has also provided guidance for me on a personal and professional level throughout this journey. And I'll leave you with my contact information. This is my email and my cell phone. If you have questions, if you want to refer to Coach or just ask questions about it, feel free to call me or text or email anytime. And thank you so much for your time.